Welcome to this high-density explainer. Look, as immunopathologists and rheumatology consultants, we deal with a ton of clinical noise. So today, we're executing the 280+ protocol. We are aggressively filtering out that noise to master systemic vasculitis. We're going to break down the exact kinetics of how blood vessels fail under autoimmune attack, stripping away all the fluff so we can focus purely on high-yield, first-principle mechanisms.
All right, let's jump right into this anatomical top-down arc. We're moving rapidly from large vessel kinetics down into medium vessel necrosis and then into small vessel destruction before putting you on the spot with a mandatory validation drill.
Starting right off with Module 1, large vessel vasculitis and granulomatous transmyelolytic kinetics. So the absolute crucial point here, the first principal concept you need to anchor on, is internal elastic lamina fragmentation. Now, this isn't just some passive swelling we're talking about. It's an active, fierce destruction of the arterial wall's structural integrity driven entirely by granulomatous inflammation. And when that elastic lamina fragments, well, the vessel loses its mechanical stability, completely setting the stage for catastrophic downstream ischemia.
Now, in clinical practice and definitely on the boards, they're going to try to distract you with what we call step 2 noise. Think vague shoulder girdle stiffness, like in polymyalgia rheumatica, or maybe an isolated elevated ESR. That is pure noise. You have to filter that out. Instead, you need to anchor onto the active ischemic signals. We're talking active ischemic retinal pathways, intense jaw claudication, or asymmetric pulses. That is your true signal for large vessel compromise.
Let's ruthlessly contrast the two major heavyweights here on the judge's bench, giant cell versus Takayasu arteritis. Notice the really distinct demographic split. Giant cell is targeting your patients over 50, usually presenting with jaw claudication and unilateral vision loss, right? It's going after the temporal and ophthalmic branches. On the flip side, Takayasu strikes young females, often under 40, with an Asian descent bias. It targets the aortic arch and subclavian arteries, giving you that classic pulseless presentation with asymmetric upper extremity pulses. And this kinetic progression follows a very strict chronology map. At step 1, you get granulomatous cell invasion straight into the adventitia. This directly triggers step 2, that critical destruction of the internal elastic lamina we just talked about. That structural collapse then leads to step 3, which is severe luminal stenosis and localized thrombosis. If you don't intervene, this inevitably culminates in step 4, permanent monocular blindness in giant cell, or catastrophic aortic dissection.
All right, shifting our focus downward in caliber, we hit Module 2, medium vessel vasculitis, characterized by transmural fibromeric necrosis.
Here, the structural failure is entirely transmural. That means the segmental inflammation weakens the muscular arteries so severely that the high systemic blood pressure actually forces the wall outward. This creates aneurysmal microvascular blowouts. Eventually, these blowouts clot off, and that leads directly to severe downstream infarction of the supplied organs.
Once again, rigorous filtering is key. If you have a patient presenting with vague systemic symptoms and renal impairment, do not get derailed by a history of illicit drug use or just some isolated hypertension. That's noise. It's literally there to obscure the true diagnostic signal. Your absolute anchor here is a positive hepatitis B surface antigen screening loop. That points you directly and definitively to polyarteritis nodosa, or PAN.
So how do we manage this? We stratify interventions based strictly on the severity of tissue ischemia. For subacute PAN, which, remember, notoriously spares the lungs, we initiate an oral glucocorticoid and cyclophosphamide trial. For acute pediatric presentations like Kawasaki disease, where you're seeing conjunctival injection and that distinct strawberry tongue, you have to urgently deploy high-dose aspirin and IVIG to protect the coronary arteries. But if you hit the critical tier, like a rapidly expanding coronary aneurysm or mesenteric rupture, you bypass medical trials completely and move straight to urgent surgical grafting or interventional angioembolization.
You really want to lock this visual into your muscle memory. This mesenteric angiogram perfectly captures those aneurysmal blowouts. See those little beads on a string? Those are the classic saccular microaneurysms of PAN, and here's a massive clinical pearl. PAN ravages the mesentery and the kidneys, but it notoriously and completely spares the pulmonary vasculature.
And downstream from those aneurysms lies the catastrophic result. When those inflamed, bulging medium vessels finally occlude, they cause a classic wedge-shaped renal infarction. The tissue just dies. This right here is exactly why aggressive early immunosuppression in PAN is absolutely critical to preserve organ function. Finally, we reach the capillary beds in Module 3, small vessel vasculitis and ANCA pausiimmune destruction. The first principle here is violent and microscopic. The ANCA autoantibodies bind directly to circulating neutrophils. This triggers explosive neutrophil degranulation right up against the fragile capillary walls, causing rapid endothelial lysis. It entirely wipes out that delicate endothelial lining, which leads to immediate hemorrhage into surrounding tissues, whether that's happening in the skin, the lungs, or the glomeruli.
Let's go back to the judge's bench to aggressively juxtapose the two main ANCA variants, GPA and MPA. The differences are striking. GPA is typically PR3 or C-ANCA positive and attacks a massive anatomical vector, upper respiratory, lower respiratory, and renal. Think saddle nose deformities and cavitary lung nodules on CT. MPA, however, is MPO or P-ANCA positive, and it completely spares the upper respiratory tract. It focuses its destruction purely on the lower respiratory tract and kidneys, presenting with purpura and crescentic necrotizing glomerulonephritis.
When those inflamed, lysed small vessels rupture into the skin, you get a hallmark clinical sign: palpable purpura. If you ran your hand over this rash, you'd actually feel the raised lesions because of the intense underlying leukocytoclastic inflammation. And keep in mind, in ANCA-associated vasculitis, this is a posse immune process. That means if you biopsy this, you'll see virtually zero immune complex deposition.
Okay, let's test your pattern recognition. It's time for our mandatory validation drill to synthesize the 280+ protocol.
Take a listen to this vignette. A 28-year-old Asian female presents with exertional syncope and transient visual blurring. Notice that massive blood pressure discrepancy, 142/88 on the right, 108/62 on the left, combined with a distinct left subclavian bruit. What's your diagnosis? Well, if you anchored onto the young demographic and the asymmetric pulses, you correctly identified Takayasu arteritis, targeting the aortic arch branches.
Now process vignette 2. We have a 54-year-old male with hemoptysis, a purpuric rash, and a spiking creatinine of 2.8 indicating rapid renal failure. He is PANCA or MPO positive, but crucially, look at the imaging. 0 cavitary nodules and 0 granulomas on his chest CT. So which vasculitis are we dealing with here?
Vignette 2 is microscopic polyangiitis, or MPA. And this timeline shows exactly how that initial autoantibody binding aggressively deteriorates into multi-organ capillary rupture. At hour 0, the MPO-ANCA binds and activates the neutrophils. By day 3, the skin capillaries lyse, giving us that palpable purpura. By week 2, the glomerular capillaries are practically obliterated, causing a massive creatinine spike. And by week 4, the pulmonary capillaries rupture, causing the hemoptysis. Because there are no granulomas and the upper respiratory tract is totally spared, we can confidently rule out GPA.
I'll leave you with this final standalone concept to ponder. Say a patient presents in your clinic with sudden onset monocular blindness and a tender nodular temporal artery. What is your single, immediate, life-saving next step before you even confirm the diagnosis? When irreversible tissue ischemia is imminent, do you wait a week for a biopsy? No way. You give high-dose systemic steroids right this very second to save their sight, and you confirm the diagnosis later. Thanks for joining me in this explainer. Keep executing that 280+ protocol. Keep fiercely filtering the noise, and I'll catch you in the next one.